Yeah. Hi, Bharat.
Hey there, good morning. How are you?
Yeah, but fine. Thank you. Thank you. So we can start.
Yeah, now I just need 1 second. I won't be able to read. Okay. Right.
Welcome all. We just wait for Mr. Oswal
I just
to
want to
start his
find
welcome address.
see which came late.
And Mr. Oswald, you probably should stop sharing
Okay.
screen too.
Okay, Sachin,
Yes, sir. Yeah.
you can start.
Yeah. Yeah. Please. Yes, sir. Yeah. Meanwhile, I would like to welcome Dr. Brandon from Chicago, Dr. Mruganka from Birmingham, Dr. Bharat from USA,
I think you need to start. I lost my contact.
Okay, should we just get started with the first person on the list, and then we can sort of backtrack from there?
Sure.
Okay.
Now I can get. Okay.
Yes. Yes, sir. Yeah.
Right. Thank you very much for all of you coming to this grand round. We have eminent speakers from USA, UK, and India. Today's topic is important. Today's topic is cancer of larynx or early cancer of larynx. Cancer of larynx, of course, is a killer disease. And apart from airway obstruction, this is the second important topic that we need to get grips on so that we can give the best possible treatment for the patient. Can I share my screen, Sachin?
Yes, sir.
Now, this is the one. Can you see the screen?
No, we can't see it, Dr. Oswald.
No?
No.
So we don't know how to share the screen. So I'm sharing the screen here, but it's not coming there. So I'm sharing the screen here. Sachin, do you have to do something there?
Sharing the screen. Yeah.
You can now?
Yes, sir.
You can.
Yeah, just go for
Okay.
a slideshow. Yeah.
Okay.
Yeah.
You can see now? Yeah.
Yes, sir. Yes, sir.
So it is incredible that in 1974, we held a 5-day conference on laryngeal cancer in Toronto in May. This was to mark the first laryngectomy done 100 years ago by Billroth, Theodor Billroth, a German surgeon. He did the first laryngectomy ever in Vienna. That was in 1874. And in 1974, 100 years later, when we were celebrating that event, I went to Canada to present a paper, an audiovisual show on team concept of laryngeal cancer, exactly 100 years from the time that the laryngectomy was done by Billroth. And this audiovisual presentation showed that surgeon just does one job of laryngectomy. But what is more important is to take care of post-laryngectomy patients. So I developed the concept of a team which you form to support the patient, not just surgeon. And this was presented in Toronto. And so 100 years later, I was given the award as the best presentation in the world because it was a world conference on laryngeal cancer. So it was incredible how. And then 50 years from 74 to 2024, I'm here talking the same thing about laryngeal cancer. So 1874 was an event, 1974 was another event, and 2024 is the event where we're talking about laryngeal cancer. So in 1974, 100 years ago, Billroth did the surgery. In 2024, 150 years ago, he did the surgery. So that's incredible. So we want to go to see what the changes that have been there. When I began my career in 1970 or 1960s, early 1960s, the treatment for early glottic cancer was radiation. And surgery was done for radiation failures. So the question was, which of the two modalities gave the best treatment option for the patient? Either radiation or surgery. Now, when the laser was introduced, this particular problem was brought forth by at a conference in Delhi. I think it was a few years ago, when we had a mock trial of medical negligence, and all the doctors took part in it. Their actors were doctors, and that particular mock trial is on a YouTube, so it's worth seeing. Radiation against laser surgery. And of course, in the end, the surgeon who was found not guilty for using the laser. So it's just a history of how we moved on from radiation to laser surgery, which is of course minimally invasive. So I just want to show you how I started laser surgery in the UK in 1982. And the first patient of cancer of larynx was not this patient, but I want to just show you that it's important to do a 70-degree scope for every patient because you don't know what's happening underneath. And another thing that I want to emphasize is we all know diagnostic endolaryngeal view. Diagnostic. Since the laser came, we now are using endoscopic view for surgical treatment. Now, when I started, say, what is this picture? Okay, it's larynx. We see it every day. What is underneath here? So I got a PM larynx and dissected it and saw all the structures there. See, this is the thyroarytenoid, vocal ligament, arytenoid, and this is in subglottic space. So when you superimpose that, now you can see exactly what the anatomical structures there are underneath. Starting from the buccal ligament, you got the thyroid muscle, goes extensive muscle, this one is. So this is very useful. And those who are going to start endolaryngeal surgery, I would urge them to do this bit of study and orient themselves in endoscopic surgical procedures by studying the structures, not as you see them here, but as you see them here. So I had to do that. And this is my first podectomy in 1982, post-radiation. For post-radiation failures would have been laryngectomy. But because laser was available in 92, mine was the first one in the country here in the UK. And I was the first one to do all this surgery here. And it's interesting. So this is about 1 minute of video. You'll see how the bulk there. So there is recurrence. The radiation did not do much for this patient. Now this laser spot is 700 micron. Okay, 700 microns CO2 laser. And it was supplied by Coherent in 1982 to us. And say how much jarring there is, of course, because it's a big spot. And when I removed the tumor and checked everything was okay, 1 week post-operatively, look at the view of healing. When I saw the healing, because I never seen it before, I asked nurses, have we got the right patient? I can't believe that cord-like structure has come there where healing takes place. So this is just an example of what laser has done for us, and we have now got experts from different countries. They're going to tell us about it. So I just want to finish this by saying that those who want to start laser surgery, you need some minimum requirements. You need a wide access. If patients are full laryngeal, long neck. I had one with a long neck. I couldn't get laryngoscope there at all. Cervical arthritis. And then you need longer instruments than normal. So always remember that, at least 70 centimeter. And then you need an experienced team, because again and again, we're dealing with a condition which is potentially fatal. Particularly, the anesthetists must be very cooperating. So we, of course, now have AccuSpot. It gives you minimum thermal damage. And the surgeon should have these various skills now. You need to have diagnosis. You need to have good endoscopy, assessment, surgical anatomy, you must know. And of course, you must know everything about the laser. So the last bit that I want to say before we start our program is oncological principles should never be overridden by any other consideration. Okay? So we now come out of this, close this, and You want to go to the CVs. Okay, I have to read the CV. We have Mr. Mruganka Day is a consultant ENT head and neck surgeon with more than 15 years of consultant experience. He's based in University Hospital, Birmingham. He gives patients a personalized service supported by the best available evidence-based treatments. As Associate Medical Director, Corporate Governance, Mruganka Day is responsible for multiple trust-level governance. He has shown his leadership in driving some of the complex multi-specialty projects with dedication, ability, and inspiration. As a tertiary level consultant at University Hospital in Birmingham in UK, he is responsible for clinical and surgical training of higher surgical trainees in all aspects of ENT. So welcome, Mruganka.
And sorry, Dr. Oswald, I think that Bharat is going to be going
I have
first.
no. I'm going to read CVs of others as
Everyone?
well,
Okay,
and
wonderful.
then we go further.
Wonderful.
Okay. Yeah. So Bharat Panuganti is a laryngeal surgeon and associate professor at the University of Alabama in the USA. He completed his otolaryngology head and neck surgery residency program in University of California, San Diego, which included a T32 postdoctoral research training year, and is dedicated to computational bioinformatics. Now let me explain that a bit. What he's doing basically is studying the margin after you do your laser surgery. Is there some malignant tissues left behind or what? So that is his research, which I think is a basic, very important research, because that's where you get recurrence. And if you can actually find, with some technical advances, that you have not cleared completely. Well, we used to do frozen section. We send ultra thin margins, ultra thin slices, sent to frozen section. I say all clear, then proceed. But technology is advanced, and Bharat is going to tell us about that advance. And then we have Paul
Sir,
Bryson.
can we start with Bharat?
Well, yeah, I just want to read Paul Bryson's CV, and then you can start, okay?
Yes, sir.
Paul Bryson is a director of Cleveland Clinic Voice Center and section head of laryngology. He enjoys all aspects of laryngeal care and particularly interested in office procedure, neurolaryngology, and premalignant and early glottic cancers. Now, we don't need introduction of Brandon, who is our co-host, and Sachin Gandhi, of course, is from India. Both of them are eminent in their own field. And thank you very much. Now we can start the program. Okay? Sachin?
We'll request Dr. Bharat. We welcome and request him to start his presentation.
Thank you so much. Can I get permission to share here, please? Is that showing up there?
Yep, we can see it. Thanks. It went away.
1 second, sorry. Brendan,
Yes.
are you seeing the
We
slide?
see the no, we see the PowerPoint screen. We don't see the slideshow.
Got it. 1 second. I apologize.
Take your time.
There we go. How's that looking?
Great.
All right, beautiful. Thank you, everyone. Thank you for the kind introduction. Really a pleasure and a privilege to be here today, and really happy to be talking to you today about early glottic cancer. Have quite a bit to get through here, so I'll try to get through all of it within the 15-minute time frame. Hope you enjoy. No disclosures. So early glottic cancer, we'll be talking about just the basic definition of it. We'll talk about some of the elements of treatment decision-making. We'll talk about intraoperative exposure briefly, and then hop into the meat of the talk, which is in contemporary advances in intraoperative margin assessment. This is information I think that's probably known to most. Early glottic cancer stipulates T1 and T2 disease according to the AJCC staging criteria. Couple functional implications of that. One, T1, T2 disease is associated with effectively a near nil risk of regional nodal metastasis. By virtue of that, standard of care stipulates, as Dr. Oswald mentioned already, single modality treatment without explicit management of the neck, which is either definitive radiotherapy and, of course, nowadays, transoral laser microsurgery. One of the most important characteristics of early glottic cancers is that there's at least partially preserved vocal fold mobility, which of course stipulates relative preservation of the underlying thyroarytenoid muscle, which itself has the implication of reducing the overall probability of paraglottic space involvement. Paraglottic space involvement obviously means that the standard fibrous and cartilaginous barriers to cranial and caudal spread are no longer present, and the incremental risk of nodal metastasis goes up. Most laryngeal cancer diagnoses, at least in the States, originate from the glottis. I'm sure that applies internationally as well. The vast majority of glottic cancer is early, so almost 80% are T1 or T2. There's some thought that early glottic cancer is perhaps an evolving pathology. Again, this is maybe more pertinent to the United States. This is based on data that we presented at the Academy conference last year. We looked at all patients that were either diagnosed or treated with an early glottic cancer at the MGH Voice Center. Found that 27% of early glottic cancer patients were never smokers, which is antithetical to the standard sort of understanding of risk factors for laryngeal cancer evolution. Decision-making, this is a topic that could be the topic of a full talk, but I'll try to condense it into a single slide. Basically, any decision to treat a cancer, whether it's surgical or not, has to be explicitly contingent on a reasonable expectation of being able to clear disease. And there are a number of factors that I think surgeons need to take into account in making that assessment. I think, and this is something that Dr. Oswald also alluded to in his excellent introduction. I think an underappreciated portion of assessing a patient with laryngeal cancer is understanding the head and neck anatomy and all the head and neck anatomic features that would influence our ability to expose the larynx adequately enough to be able to clear disease. I think an important point to note for anybody getting into this is not all early glottic cancers are the same, even if they're the same stage, and that's particularly true of T2 cancers. This is a spectrum of T2s that I've seen and treated over the course of the last couple of years. As you can see, they're all basically fundamentally different. Top left is a massive hemilaryngeal verrucous squamous cell carcinoma that faced basically the entire right hemilarynx. This was not a candidate for radiation. It's a verrucous squamous cell carcinoma, but because of the exophytic pattern of growth, they did excellent from a functional perspective postoperatively. The bottom left is another T2 for hypomobility. This is a really endophytic tumor. This stipulated almost a complete chordectomy, and a portion of the arytenoid had to be resected for posterior margin. And then the bottom middle is fundamentally different than the last two that I just mentioned. Really sessile disease involving the right vocal fold with marginal involvement of the vestibular fold because it's transglottic, officially T2, but of course the surgery for that tumor is fundamentally different than the other two. And to that end, I think it's important to differentiate among T2s especially a wide geographic footprint. So transglottic disease and hypomobile vocal folds are two fundamentally different characteristics of a tumor, but both of them make them stage 2. And I think it's important to understand that there is disease heterogeneity even amongst T1 and T2 early glottic cancers. I think the decision to pursue radiotherapy versus surgery is complicated, and it can't be just based on an interpretation of population level data. Most of the large population level data is encumbered by disease and treatment heterogeneity, and really the absence of really sound comparative longitudinal functional data, obviously pertaining to voice and swallowing. I think a question that really represents the complexity of choosing radiotherapy versus surgery is, would you rather have an incremental glottic insufficiency from a focal soft tissue deficit, or would you rather have a mild difficulty swallowing solid food stuff as a consequence of long-term radiation-related pharyngeal and constrictor fibrosis? Not every patient is the same, not every surgeon is the same, not every situation is the same. And more than that, how do you gauge the risk of burning a treatment modality as valuable as radiation, particularly when we're seeing patients with early glottic cancer and early age, where the risk of a second head and neck primary is not insignificant. I think it's impossible to declare that a disease process based on stage or appearance endoscopically is officially and definitively a better candidate for one treatment modality versus the other. But I think as surgeons, what we do have the opportunity to do is account for a number of characteristics to maximize the probability of treatment success. And hopefully over the course of today's webinar, that becomes apparent to everybody here. I wanted to include this really nice study out of Italy that summarized the spectrum of head and neck and anatomic characteristics that are really important to consider prior to continuing with a surgical laryngeal procedure. Some of these are obvious and intuitive: inter-incisor distance, of course. Thyromental distance is something that I assess in all patients before taking them to the operating room for an endoscopic laryngeal cancer resection. That stipulates the distance between the tip of the chin and the thyroid notch with the head extended. You want that to be at least 4 finger breadths as a basic metric dictating how easy it's going to be to align the oropharynx with the larynx with a straight, rigid laryngoscope. The laryngoscope can't bend, so the only thing that can give is the patient's anatomy. And if there isn't enough space between the oropharynx and the larynx, it's going to be a lot harder to get a view of the anterior larynx. The other most important characteristic, in my opinion, is the floor of the mouth and the volume of the submandibular region. If someone has a big tongue, a narrow mandible, and/or mandibular tori, there's not enough space for the tongue to be displaced. If the tongue can't be displaced, you can't get the laryngoscope in. If you can't get the laryngoscope in, you can't see. And those are the basic characteristics. I'll often just grossly, obviously, just look at the size of the tongue. If they have a big tongue but a wide mandible and no tori, that's usually not a problem. But if you have all those characteristics, that can potentially be problematic. I'm not going to spend too much time on this slide, but I did want to bring up some elements of intraoperative exposure that go beyond head and neck anatomy. This is a slightly dramatized set of pictures, I think, comparing the Dito laryngoscope on top on the left with a universal modular glottoscope on the bottom. The universal modular glottoscope is a scope system that was developed by Stephen Zeitels, who was fellowship mentor to me, Dr. Baird, and Dr. Bryson, all on this call currently. But I think it does have some competitive features that make endoscopic laryngeal cancer resections a lot easier. The distal end is shaped like a triangle, lancet shaped like the glottis, so it gives you better distension of the supraglottic soft tissue more universally to get a better view of from the top to the bottom, or the anterior to the posterior glottis. That's particularly important in situations where you're exposing the superior surface of the anterior commissure, and situations where there's anterior disease. Really gives you a great view of the infrapedial mucosa. That's a place that you don't want to leave disease. I think the biggest advantage of the system is actually the suspension gallows. That's the diagram that you see at the top on the right side. Standard scope systems function with a fulcrum securement arm. So the way that you position it, the scope, and hold it in position, cantilevers against the maxillofacial skeleton, which is fixed. The suspension gallows pulls up against the mandible, which is connected to the head by soft tissue. So you can really maximize anterior excursion of the scope and really maximize global view of the inside of the larynx. In my mind and in my practice, this is a critical portion of being able to do these surgeries. I wanted to bring up the study because, again, as surgeons, we're forced to make a calculus for every patient that we see, and I think it's important that not only we understand when it's appropriate to move forward with transoral laser microsurgery, but also understand the implications of failure. And that was really the question that we asked with the study. We looked at 550 patients that underwent TLM for an early glottic cancer. Really, the question was, if patients fail TLM, have recurrent disease or persistent disease and need either radiation or an open surgical salvage, what are the survival implications of that? And what we found is that patients that, of the 553, about 100 needed a different treatment modality. That 100 patients did not do worse from a cancer-specific or overall survival perspective at 5 or 10 years. So this has no bearing on function, but at least from a survival perspective of early glottic cancer patients, if TLM doesn't work, you do have options to salvage it without sacrificing a patient's survival, at least on average from a population level perspective. All right, so let's jump to the meat of the talk. This is something that's particularly interesting to me and is the basis of a lot of the work that I'm doing currently. This is a really nice study that was published in 2009 out of Italy. They looked at 274 patients with an early glottic cancer that underwent chordectomy. If you look at the bottom of that table on the right side, what you see is that cumulatively, patients had positive margins, true positive margins, not even just close, but true positive margins about 20% of the time. And if you think about a surgery that has positive margins 20% of the time, that has to give you pause and make you think about whether or not we're doing the right thing for the patient or doing the surgery the right way. I think we have some tools at our disposal to make this surgery better. And I think of the things that we've accomplished as a field in optimizing the way that we treat early laryngeal and early glottic cancers, this is sort of the last horizon that really needs to be optimized. And I think there's some pretty interesting ongoing work to that end. I want to focus this discussion on the intraoperative tumor mapping and margin assessment tools, which I think they're two ends of the same snake, basically. But I want to focus it on techniques that are familiar to me and, in my opinion, and in my empirical use, have the most value. There are a number of intraoperative imaging techniques. I don't think we have time to discuss all of them, but they're primarily designed for mucosal margins, right? So the most available intraoperative imaging and margin assessment tools that we have are really designed for superficial margins and not deep submucosal margins. I think the most familiar to everybody probably on this webinar is narrowband imaging and iScan, both of which represent modalities that are contingent on real-time chromoendoscopy, so filtration of specific wavelengths of light that give us better definition of specific structures. And in the case of narrowband imaging, of course, that's the intraepithelial microvasculature. Optical coherence tomography, not going to really touch on, at least in my opinion. I don't know if it has any contemporary value for endoscopic laryngeal cancer resections, at least in my hands. Confocal laser and microscopy is something I'm very excited about, in addition to tumor-specific fluorescence. And let's touch on some of that. Narrowband imaging, as I mentioned, more than likely the most accessible adjunct that we have as surgeons in the operating room. It's based on the presence of two illumination beams, the wavelengths of which are maximized at 415 and 540 nanometers, which really allows us to elucidate the, as Nee described it, the intraepithelial capillary loops. There are different schemes to help surgeons interpret findings on narrowband imaging. I think probably one of the most familiar ones is this Nee criteria that was published originally in 2011. That group defined 7 different subcategories of NBI findings contingent on a number of mass lesions. And I think to that end, if you look at a lot of the analysis evaluating the efficacy, sensitivity, positive predictive value, specificity of narrowband imaging, a lot of them are really based on mass lesions. So lesions that you can see with simple white light endoscopy, but defy immediate diagnosis just based on whatever characteristics that they have that don't immediately potentially suggest cancer. And excellent pooled sensitivity, 78% in specificity, looking at these large meta-analyses and differentiating high risk from low risk leukoplakia. And I'll show some videos in just a couple slides, but really I think the question that we as surgeons need to ask, narrowband imaging is tremendously useful in some situations, but what is its relative benefit in differentiating truly subclinical disease? And I think that's where the pitfall lies, even with high definition surgical microscopy that a lot of people have access to. How do we see disease that we can't see? That sounds like a paradox, but that's really the question that I hope to answer with some of the research we have ongoing here. I'm just going to quickly mention that table at the bottom. You can see the different vascular patterns. I think most people that have used NBI are really familiar with the basic appearance. Vascular stippling, of course, each one of these categories is associated with a relative risk of atypia, low-grade, high-grade dysplasia, and cancer. But ideally, we want to get a little bit more specific than that. So that's where this next modality really comes in. Confocal laser endomicroscopy. There are a couple different systems that are available on the market for confocal laser microscopy or endomicroscopy. The system that I use is the Cellvizio system that's developed by a French company called Mauna Kea Technologies. And again, I'll show you some videos and pictures here. But what CLE is it allows us to get a 1000x surface-based magnified view of the cellular and subcellular morphologic characteristics of squamous epithelium. And really what you get is basically real-time cytologic evaluation. And it's all based on differential fluorescein uptake. And fluorescein is not a difficult dye in general to get of the things that we can use intraoperatively. This is a technique, as long as you have the machine, that is relatively accessible. I think what you get with CLE, and again, I'll show you, but what you get with CLE relative to narrowband imaging is a much wider spectrum of cellular and subcellular morphology that gives you the opportunity to get very granular and help to start differentiate between benign, low-grade dysplasia, high-grade dysplasia, carcinoma in situ, and cancer with a lot more specificity. This is, of course, a surface-based modality. The depth of penetration with the camera here is only 55 micrometers, so it doesn't even get to the bottom of the squamous epithelium of the vocal fold. So if we're not looking at the basement membrane, we're still extrapolating whether or not a tissue demonstrates cancer. But I think what you'll see here is that becomes quite easy. All right, so this is a T2 cancer I've exposed with a glottoscope. You can see the lancet shape of the laryngoscope. This is the probe here, just injecting the intravenous fluorescein. It takes about 5 to 7 seconds before you get penetrance. We're seeing keratin pearls there, the posterior aspect of the vocal fold. And this is what I'm doing at the beginning of basically every case. I use this as a way to sort of map the tumor, even outside of standard margin assessment. At the conclusion of the case, in order to assess the peripheral mucosal margin, I like to use the modality to help me understand the basic footprint of disease, not just to see the gross tumor, but also to understand whether or not there are foci of disease in areas of grossly normal mucosa, even by NBI criteria. I'm just going to play that again because I think it's really cool. But those are individual microcapillaries. You can actually see individual red blood cells based on the amount of magnification that you have. That's it on gross tumor. What you want to see is it's a honeycombed appearance with the cells manifesting a homogeneous polygonal architecture. And that is what you can see on this last image here. If you remember from the very beginning of the video, I had that probe positioned maybe 0.5 millimeter away from where it is now, and it looked grossly abnormal. Move it just a 0.5 millimeter over, and now we're seeing grossly normal tissue or grossly normal morphology. And this just goes to show you, especially with the glottis, tumor heterogeneity is a big thing, and it's very difficult to perform a narrow margin surgery without sacrificing margins, and as you could tell from the study I mentioned a few slides ago. this is data that we are is submitted that isn't yet published, but I wanted to bring it up in today's talk because I think it's a really nice illustration of the potential value of narrowband imaging and confocal laser and microscopy. The figure on the left, tumor on the left side, right-sided vocal fold, and I'm looking at the table on the left. Sorry. If you look at panel A, you see 3 different images. You have image in the clinic, image in the operating room with a flexible bronchoscope, and then with a 8.7x surgical microscopy. Tumor on the left vocal fold, but the right-sided vocal fold, really thin sheen of keratosis posteriorly, but anteriorly, the actual mucosa itself actually looks pretty good. Second panel, we have narrowband imaging really focused on the anterior right vocal fold. We see the dilated microcapillaries in the epithelium anteriorly. But outside of that, really no indication at all that there's anything more potentially than cellular atypia according to the knee criteria based on NBI findings. We put the CLE probe on there and look at what we see. We see distorted cellular architecture. And this is hard to explain without having a basic understanding of what to expect to see on CLE. But again, we're seeing distorted cellular architecture, heterogeneity. There are regions there where the margins are blurred. There are irregular cell junctions, fluorescein leakage, all characteristics highly suggestive of dysplastic tissue based on staging criteria that we're in the process of finalizing and hopefully publishing soon. So if you look at NBI criteria, maybe cellular atypia. If you look at CLE criteria, high-grade dysplasia, and that was corroborated based on a histopathologic assessment of a small volume biopsy in that region. And again, similar situation there in panels D and E. The second table there I wanted to include because I think that narrowband imaging and confocal laser and microscopy have the opportunity to work really synergistically. This is that large verrucous squamous cell carcinoma I showed at the beginning of the talk. I'm looking at the contralateral vocal fold. All right, so if we think about how to use this technology, it has no value in situations where we can clearly see what's abnormal. Where it has value is in situations where we can't obviously see that something is abnormal. So we're looking at panel B at the contralateral vestibular fold, clearly see that vascular stippling potentially suggestive of dysplasia by NBI criteria. We put the confocal laser and microscopy there, we're seeing keratin pearls, and there's no other situation that we would see that outside of at least carcinoma in situ, really, truly cancer. That histopath demonstrated mild dysplasia. And this is the perfect indication where with small volume biopsies, which Dr. Rosewall already alluded to, small volume biopsies, particularly frozen sections, oftentimes you can't rely on them because the pathologist is handcuffed. We're not giving them large chunks of tissue. So to have other information in the operating room to be able to rely on to help us decide what's cancer, what's not, what's at risk and what's not is potentially extremely useful. Especially in situations where we're dealing with small early glottic cancers where we can't take big chunks of tissue for the pathologist to feel comfortable about relaying sound data or sound interpretation of whether or not there's some cancer or not. What about the deep margins? And I'm sure I'm running out of time. I apologize for that. Just a couple more slides. This is another shameless plug. Part of a phase 1 clinical trial I have ongoing looking at panitumumab iodide 100. So this is a dye that we're using for the assessment of deep margins, right? So this is not limited by surface endoscopy. Panitumumab is a monoclonal antibody to EGFR, which is overexpressed in head and neck cancers. It's paired with iodide 100, which is a near-infrared dye that can be imaged with a camera capable of near-infrared excitation. So this is a really cool case, early glottic cancer. This individual came in for an infusion of that dye. Takes place over about 45 minutes, 24 to 48 hours before the surgery. And I'm going to show you some videos here. So let's see. Okay. So this is the tumor exposed in the operating room. This is just white light endoscopy so that you can see the margin of the tumor. Right vocal fold, really sessile, extending to the vestibular fold on the right side. I use the XI, the Da Vinci XI camera on advanced Firefly mode, which allows for near infrared excitation. And what we're seeing is really clear definition of that tumor. And the Stryker pinpoint's just another camera that we use. Again, seeing what you can see, obviously, by white light endoscopy has no value. Where these imaging techniques come into come into play is in identifying whether or not small volume disease represents cancer. This is a standard ablative resection with which Dr. Baird will talk about soon. I leave a thin rim of what obviously needs to be removed on the vocal fold, and you can see on that right vocal fold the clear delineation of tumor that's remaining. This dye can be seen with a near-infrared camera in volumes as small as 450 cells. So this is truly a way for us to be able to identify and address microscopic disease. Go for that final round of ablation, and you will soon see that uptake on the surface of the muscle is now gone. Anyhow, this is a really interesting space and something I'm really excited about. That's the end of the talk. I'd be happy to take any questions and certainly collaborate with anybody interested in the discussion section. But again, thank you for your time, everybody, and thanks for the invitation to be here.
Thank you.
Hey,
Thank
I
you.
just wanted to congratulate
Can you hear me?
you
Now?
Yeah.
on this. Yeah, can
Yeah.
you hear me?
Yeah, okay.
Yeah.
Brandon, now we started with CO2 laser when we started in neurology. And then other lasers were introduced, particularly the KTP. And the advantage of KTP is, of course, fiber transmissible. CO2 laser is not truly optical fiber transmissible. Okay? So, Brandon.
I think Paul's going to say something really quickly while I get set up, if that's okay. Paul, I know you wanted to say something.
Oh
so
yeah,
I'm
real
just gonna
quick.
get my,
No,
Mhm.
Bharat, I wanted to congratulate you on this work. It's you know, there hasn't been a lot of this done in laryngeal cancer for a while, and it really does sort of it's really provocative as to to add to the precision of transoral resection. I wanted to ask you, have you had much enthusiasm with some of our other head and neck oncologic colleagues? You know, you can imagine applications of similar stuff maybe in the oral cavity, you know, specifically with tongue or with supraglottis. You know, what's your as you look to maybe expand awareness and access to this technology, have you had interest from, you know, our colleagues who might operate on other subsites in the head and neck?
Yeah, thanks, Paul. Appreciate that. Yeah, so tongue is a bit challenging. I guess to answer the first question, yes, I think there's a lot of enthusiasm. We at UAB right now are using it with, or my head and neck colleagues are using it for TORS or pharynx cancer resections. And we've used it for a few hypopharyngeal cancer resections. So at least for me personally, at UAB at least, there's been a lot of acceptance and enthusiasm around this. I think the applications in the oral cavity are a bit limited, and I know this is outside of the scope here, but the tongue has papilla, and it makes the surface assessment a lot harder. It can be kind of persnickety, so having really nice, clean, smooth squamous epithelium is basically a prerequisite for using the confocal laser endomicroscopy. That being said, I think the data is going to speak for itself, and it's going to be hard for anybody to argue with the data. Ultimately, is my hope. But yeah, I think there's a lot of potential for this to be applied across ENT. And there's a group in Germany that I'm working with that's used it for a ton of stuff, open laryngectomies, and now they've broached nasal cavity and nasopharyngeal cancer resections using the device.
Brandon, we can start with.
Yeah, sure thing.
Brandon, yeah.
Thanks again, Bart. This is really incredible
Thank you,
work, and
Bharat.
it's great to be able to follow you and talk a little bit about the use of the KTP laser to treat early glottic cancer, and then also talk about some of the office-based options that we have. Really quickly, no financial disclosures. I have an investigator-initiated trial that's not relevant to this talk. I want to thank again Paul Bryson and Bharat for coming and speaking here. I want to thank Dr. Gandhi again for putting this together, Dr. Bisha, and again Dr. Oswal for moderating. I'm going to really quickly just go through the evolution of the KTP laser as it relates to the CO2 laser's history. And so, as many of you know, CO2 laser was initially described by Strong and Yako back in Boston in 1972. It's very interesting. We're talking about the history of early glottic cancer and the laryngeal summit that Dr. Oswald talked about, because all of these sort of histories are intertwined. Because Yako was at Boston University Medical Center, and he was the mentor to my mentor and our mentor for Paul and for Bharat. He was followed up in terms of developing the CO2 laser by Charles Vaughan and Stuart Strom. And that sort of was handed then down to our mentors. So I'm going to really quickly talk about the physics of the CO2 laser. As many of you know, the chromophore for the CO2 laser is water. So it has an indiscriminate approach to addressing tissue and treating, mostly cutting through tissue non-selectively. You can see sort of the coefficient of absorption here. And the way that CO2 laser was historically used to treat cancer was to basically identify the deep margin of the tumor and resect the tumor anterior and posterior to that sort of initial cut, which left a significant defect or hole in the tissue, which was certainly detrimental in terms of the outcomes that we care about. As many of you know, early glottic cancer has a pretty reasonable survival, overall survival and mortality. And so what we really use to determine our success in this field is very much outcomes, swallowing, and more importantly, voice. And so it's important that we take microscopic margins, and I think it sort of reflects back as to what Bharat was talking about specifically with regard to margin status and being able to identify where a tumor is and take only what you need, basically, to clear disease. The KTP laser uses a different chromophore. It's oxyhemoglobin with an absorption at the 532 with a wavelength of 532 nanometers, which is absorbed preferentially by blood. And so, as you saw before, the vascular anatomy in early glottic cancer has aberrancy that allows us to specifically select for disease while allowing for collateral tissue to be sort of relatively untreated and preserved. Again, kind of reflecting what Bharat mentioned was sort of the identification of specific vasculature that is very intrinsic to early glottic cancer or dysplastic tissue, specifically looking for things like capillary loops, punctate vascularity, and abnormalities with regard to the vasculature that's away from the normal arborization, as you can see in this sort of panel A. And that's what we sort of use as our historically have used as our sort of identification for our margins and our sort of extent of disease until Bharat presented some of the work that he's done. So it really is an exciting space, again, to commend him for that. The laser was first initially developed and studied back in the early 2000s, the early aughts. And one of the first studies that was used to sort of identify its mode of activity as well as its safety was the CAM model, or the chorioamniotic membrane model, which another one of our mentors, Jim Burns, helped to sort of perfect. Looking at the pulse length, or sort of the pulse width, a 15 to 35 millisecond pulse width, regardless of the wavelength, allowed for cooling of target tissue after ablation, which decreased the amount of thermal damage in tissue that was treated with the KTP laser. This was sort of subsequently used to evaluate coming up lasers that are coming up, including the blue light laser, and I'll get to that in just a bit, but I'm not going to focus too much on this. I'm going to focus more on technique and sort of the principles of treating disease with the KTP laser. But essentially what we want to talk about is sort of what our typical or standard settings are going to be. And we typically, or at least most of the people that trained at Mass General, use a pulse width of 15 milliseconds for the vocal folds themselves, anywhere from 26 to 30 watts in terms of power. Although when you're treating areas outside of the vocal fold epithelium, you can go all the way up to 45, 60 to work a little bit faster. But this setting with 2 pulses per second allows for sort of the optimal sort of balance between treating tissue and preserving collateral or adjacent tissue that's normal. So let's talk briefly about the principles for photoangioablation of cancer, and the same kind of principles taken for papilloma as well. So the KTP laser induces selective heating of the lesion subepithelial and intralesional microcirculation. It minimizes the thermal trauma, as I mentioned, minimizes fibrosis of the extralaryngeal or extralesional tissue, And it optimizes for preservation of the mucosal pliability needed for vibration and then also subsequently voicing. So you can see here, this is sort of a sped up version of what the KTP ablation of tumor looks like. It's not a standard approach as you would see with the CO2 laser where you're kind of cutting around tumor, but instead you're photoablating and you're identifying margins anterior to and posterior to the lesion and making sure that you get everything. And we'll talk a little bit more about sort of how that approach can be sort of optimized. And how one can kind of approach that sort of ideally, but it really does, it is more of an art than a science. And a lot of the techniques I talk about here, I think will allow you, if you decide to do this, to be a little bit more successful in terms of recurrence-free survival and also in terms of functional outcome. So this is just an example of a patient that had a midfold squamous cell carcinoma. You can see here the vibratory limitations of the tumor itself on that left vocal fold, midfold, kind of an ideal candidate for KTP laser ablation. And so the surgery itself requires, again, exposure, and I'll talk about this a little bit further, because you essentially have to be able to identify all sort of dimensions of the disease before you even get started. If you can't adequately expose, you need to really kind of consider whether or not this is surgery that you should be doing for this patient. And so, as you can see, the laser is it's 2 pulses per second, so it's a pretty frequent cadence there. And you're essentially just ablating through tissue. You're getting down to an area below the tissue where you start to see tissue change. Historically, we've used sort of the response to laser, whether or not the tissue curls up almost like cottage cheese or if it stretches almost like saran wrap, as a way of helping us distinguish normal versus abnormal tissue. One thing that you'll see here in this specific patient is that there was a little bit of a deeper section, and as a result, you'll see on the next slide, there's a vibratory limitation for that patient in terms of their ability to phonate. Voice is still reasonable, but they do have some limitations. And so this is their post-op vibratory capacity here on stroboscopy. And you can see that the right cord still vibrates normally, but the left cord has some vibratory limitations. And so just as with the CO2 laser, you can still have problems with vibration with the KTP laser. It's not perfect. So what's the technique? What are some of the ways that we sort of optimize our treatment environment and clear disease? And so I'm going to kind of go through these specific recommendations, but certainly I'm sure others on the call will have their own specific approaches for how they do this. For me, the paramount thing is exposure, as Bharat mentioned. I will spend sometimes up to 30 minutes, sometimes 40 minutes in a really difficult exposure patient, really trying to optimize the view that I have not only of the tumor, but of anterior commissure, of the lateral aspect of the fold all the way into the ventricle. And there are a couple of things that can be done to optimize exposure intraoperatively as well. Important to treat anterior commissure disease prior to performing the subepithelial infusion. And the reason we do that, typically the subepithelial infusion, as I'll get to later, helps to preserve underlying either superficial lamina propria or lamina propria. However, when you do that, you'll see is that it sort of prevents access to the very front of the vocal fold. So treating the very anterior, almost anterior 1/4 of the cord first with T1 disease is helpful prior to performing your subepithelial infusion. Cord spreader is vital, especially for anterior commissure disease, which tends to have a higher failure rate. Subepithelial infusion we talked about previously, and then oftentimes resecting the false vocal cord to access the lateral extent of disease is helpful. Now, a couple of things that have been mentioned before in terms of teams is speech pathology. Certainly having an appropriate anesthesia team, as Dr. Oswald mentioned, having appropriate nurses, et cetera. But I think more importantly, and as Bharat mentioned, than all of those others is a reliable pathologist. You can't do this in a place where you don't trust or you don't sort of have a lot of confidence in the reliability of the frozen section that the pathologist assesses. So I have a very close relationship with a pathologist here at University of Chicago. I will reach out to her the day before my cases and let her know, hey, there's a frozen section that's going to be coming down the next day. And she'll be on call sort of to look out for that specimen. And I know that I'm going to get a more accurate sort of evaluation of what I'm sending based on her assessment. Now, as Bharat mentioned as well, we're taking small frozen sections, margins from around our treatment area. And that makes it very difficult for them to come up with an accurate diagnosis. We're not giving them a lot of tissue, again, because we're trying to preserve as much of the underlying tissue as possible. And so really, it's really this balance between giving them enough tissue that they can kind of definitively make a decision about what they're seeing without kind of bagging your voice outcomes at the end of the day. So exposure, exposure, exposure. So, full exposure, like I said before, is required even to get started. Oftentimes it's said that anterior commissure disease is more aggressive or that it's more dangerous, and that's actually more of a sort of a misunderstanding. What's oftentimes the case is that anterior commissure disease is where the surgeons fail most. Adjuncts to assist with poor exposure include things like the cord spreader, which we'll talk about later. This concept of internal distension and external counterpressure. And so Bart had a great picture there of the universal modular glottoscope, which is a true suspension system. And what it does is the universal modular glottoscope pushes away the false vocal folds and internally distends the larynx, giving you sort of optimal exposure of the vocal folds. Whereas a externally placed piece of what we use as tape on the sort of anterior cricothyroid membrane helps to bring the vocal cords and also the larynx into view into the glottoscope. What this does is it gives you adequate assessment and visualization of the anterior commissure tendon, which is your ideal sort of exposure exposure sort of landmark to be able to say, hey, I've gotten all the way to the front. Again, true suspension laryngoscopy. We're not talking about a Dido and a Louis arm or a Lindholm and a Benjamin arm. You truly have to be able to do suspension laryngoscopy, and that really is adequately performed with a gallows suspension system, as Bharat mentioned before. I will oftentimes ensure, especially if there's a tumor that's creeping towards the anterior commissure, I will ensure that I've gotten adequate exposure by taking a small frozen section margin at the very start of the case to identify my ability to get around the tumor anteriorly. If that frozen section or margin comes back as positive, I will readjust my exposure and or treat further forward and take a new margin. Couple of things that are needed that you have to be able to kind of keep in mind when you're talking about exposure. You're looking through two eyes. You're not looking through one eye. So having an adequately sized scope is important. You're performing surgery with two hands. So you have to be able to make sure that you can see everything you need to with your instruments in view. Again, we talked about margin assessment previously. And then you want to make sure that if you're using a CO2, like with the micromanipulator, that you have the direct line of sight. You're not limited in that respect with regard to seeing and treating. Couple of DL exposure risk factors, as has been mentioned before: short jaw, large tongue, obesity, TMJ, radiation fibrosis, large incisors. Tucked or folded epiglottis is a very important concept, especially with the universal modular scope. As you can imagine, if you have an anterior commissure and you have disease that's going towards the front and the epiglottis tucks under, it's going to potentially limit your true exposure of the anterior commissure there. A couple of options to address difficult exposure. In some patients, you just decide, okay, this is someone that might not be able to have surgery, and you can kind of decide to treat with radiation. But as Bharat mentioned as well, with the younger sort of profile of patients that are having or at least being diagnosed with head and neck cancer, we want to sometimes save radiotherapy for patients that are older, so that they have other options. So let's talk about anterior commissure disease and the cord spreader. A lot of surgeons will just treat what they see, and really you don't have the exposure that you need without truly using a cord spreader to get at the very front. The other thing about the cord spreader is it can also decrease your collateral damage to the contralateral vocal fold in a unilateral disease. So as you can see, there's some sort of collateral damage, some friendly fire here on the left vocal fold potentially. Whereas if you have the cord spreader, you have a little bit more access, a little bit better access to the very front, and you can kind of be a little bit more specific in how you treat. The other thing that a cord spreader can also identify is sort of how extensive disease is, specifically as it relates to the anterior commissure. Some patients that are seen in preoperative laryngoscopy or stroboscopy seem to have more extensive disease than they actually have. So a cord spreader can help you delineate that by giving you sort of a true sense of what the anterior commissure looks like. For instance, this was a patient I saw who had what seemed like maybe disease that crossed over to the other side. And this ended up being a unilateral lesion at the end of the day. So again, cord spreader is super important. And this was their post-op. Stroboscopy. Let's see. She doesn't like her scope exam, so we'll skip by that. All right. All righty. So the other thing that helps to protect the underlying lamina propria is a subepithelial infusion. As many of you all know, this is something that has historically been done with the CO2 laser for a very long time. It provides a layer of expanded lamina propria. It allows for improved voice preservation. It also increases tension on the tissue, which is I think, more important for KTP laser ablation than it is maybe even for CO2. What the tension on the tissue allows is for being able to identify and see that sort of differential effect in treating disease versus non-disease. So again, doing an injection, you'll sometimes see that there's more of that sort of cottage cheese curling up kind of appearance to diseased tissue that's being treated versus that saran wrap being pulled kind of appearance to normal tissue being treated. So this is unfortunately a patient with nodules, but you get the idea in terms of a subepithelial infusion. You want to make sure that you're just underneath the epithelium. You want to make sure that you are injecting slowly and that you see an expansion of the SLP. And this, in an ideal world, will sort of push your lesion off of the underlying ligament. It can also be diagnostic to tell you how deep you're going to be treating with the ultimately with the KTP. The other thing it also provides for us is that a lot of us use adrenaline or dilute adrenaline or epinephrine to decrease the amount of bleeding that you have while you're doing your resection. So for all of these reasons, can be super helpful. So oftentimes disease extends laterally into the ventricle, and a vestibulectomy or a false vocal fold resection is necessary to be able to treat disease. Either the CO2 laser or KTP on continuous mode at 5 watts can be used to unroof the entire ventricle and remove the false vocal fold. It's also excellent for subsequent surveillance on either stroboscopy or laryngoscopy. So this is a patient who had disease that appeared to go out to the ventricle. You can see sort of the involvement there. And, you can see maybe the margin here, but you don't have a great view. And so this is a patient that ended up having their false cord removed. And this is something that can just be done at the very start of the case. And what it does is it really kind of exposes nicely the entirety of the tumor, the lateral aspect, and you can kind of really nicely sort of treat what's there. And so I think this is probably the treatment now that they've been exposed here. And again, treating anteriorly, you have to make sure that you're not treating the contralateral side. If you're able to, given the risk of anterior commissure web that can form after treating both sides. And you can see sort of the difference in terms of how the tumor reacts versus how normal tissue reacts. Normal tissue tends to have, again, that sort of saran wrap appearance, and tumor tends to have that a little bit more of a cottage cheese appearance when you're treating it. This is the patient post-operatively. Essentially, you can see that this vocal fold looks a little bit bigger than the other side. It's actually, in fact, the fact that the false cord's been resected on this side, and there's still some well-preserved pliability there that's maintained. So, finally, how do we address residual or recurrent leukoplakia, recurrent dysplasia? Occasionally, you'll see recurrence appearing after the resection. You'll see something that looks abnormal on your subsequent surveillance laryngoscopy or stroboscopy. Oftentimes, I'll talk to patients about doing a second stage procedure. Usually, I'll do this anywhere from 6 weeks to 2 months, 2 to 3 months after the surgery. I will biopsy with an intraoperative Furzen section. And most of the time, what you see is either lower high-grade dysplasia. The sort of idea is that, and as Bharat has mentioned, is that you're seeing likely with a white light and or an MBI, you're seeing a lot of things that look diagnostic. But until we've had something like the endoconfocal microscopy, you're not necessarily seeing all of the areas of dysplasia. And so probably what you're having is sort of this field cancerization phenomenon, and you're seeing dysplasia, dysplastic lesions that are coming back. The question is how quickly or how aggressively you should treat those dysplastic lesions. And actually, Lauren Tracy had a great paper along with the MGH group looking at wound healing after surgery, and identified that basically 3 months is the ideal time frame to treat or to identify tissue that might be more dysplastic. When they took biopsies prior to 3 months, it was more likely to be just granulation tissue. After 3 months, more likely to be dysplasia and or recurrent carcinoma. So you'll oftentimes treat with the KTP at a second stage. You can also, and so you'll wait 3 months. You can also treat in the office as well. And this is my last slide, When you're treating dysplasia, the approach is a little bit different. You're treating with a laser, and what you're trying to do is basically decouple the dysplastic tissue from the underlying superficial lamina propria, and basically to photoablate the vasculature, which basically pulls it off of the underlying vocal fold, which you can then sometimes even peel off of the vocal fold itself to kind of give yourself an ideal sort of resection with limited injury to the underlying structure. And then finally, the office-based procedures we talked about before. This is a patient who had recurrent severe dysplasia, and this is sort of what this looked like. He'd been treated in the office multiple times because of considerable cervical spine issues, so we couldn't take him to the OR necessarily. He had a pre-existing web when I met him. He also had a small granuloma on the left-hand side. And over time, every year, he starts to get more and more hoarse. This is a little bit of topical application of lidocaine. And then this is the lasering of the disease here. And you can see that it sort of is in a patient that has a very mobile vocal fold, so you sort of have to try to time your laser hits with the patient's movement. And essentially, you can do either contact mode or non-contact mode to treat disease. Again, you want to keep this energy low, so I usually use 26 or sometimes 30 with the same pulse width and the same pulses per second. And you can see that upon return here, he has a pretty decent appearing strobe exam. Has a little bit of a lesion that's still there on that left-hand side, or that's sort of increased on that left-hand side. But it's something that allows you to sort of treat this recurrent dysplasia, and especially in our patients that have had prior cancer, in a way that's sort of minimally invasive, doesn't require general anesthetic, and can help to preserve voice outcomes. So I'm going to stop there because I think I'm a little bit over time. But thank you so much again for your attention, and I'll turn it back to you, Dr. Oswald.
Thank you, Brandon. I think we are pushing for time. Sachin? Next paper is for Sachin.
Yes, sir.
With carbon dioxide later.
Yeah.
But
I'm just going to stick to some.
we're just going over time. Okay.
Yeah.
All right. Okay.
Yeah. Thank you. We just now go. Whatever points we have already have discussed, just sorry, I'm just
Shall we try with Mr. Day, and then you come
yes,
after that? Mr. Day?
Yes. Yeah, Mr. Day, you can start. Yeah.
Raganka?
Yes, I'm there. Give me a
Raganka,
second.
are you
Yeah.
able to start? Then
Yeah, I can start.
Sachin Gandhi after you. Yeah.
Yeah, no problem.
Okay. Thanks. McGregor is going to talk to us on robotic surgery, and of course we know that at the moment supraglottic cancer is accessible, and there's some work going on access to glottis, which is difficult. Thank you.
Can you see my presentation?
Yeah, we can see your screen. Yeah.
Yeah. Okay, thank you. I'm going to take not very long, and I can see the talk's been slightly in a higher level than what I'm going to tackle. Thank you very much for invitation, and what I'm talking is supraglottic cancer management. Supraglottic cancer, especially in the English-speaking world, still being treated with radiotherapy and chemoradiotherapy. And I'm very fortunate in a way that I started in a place called Derby, which was heavily influenced by Steiner and Steiner techniques. So 2008, I started being a consultant, and I have been using on around both the laser and the robotic skills to tackle this disease. But I'll re-emphasize, we have to be careful about the patient selection. And that is the important facet here. And therefore, not every single supraglottic cancer is going to be amenable to organ sparing surgery of some description, whether it's robotics or laser. And you will see that I've shared some of the videos are laser, and I've got one or two of the videos with a robot. So that's very important. Now, one of the panelists has already alluded to that. The head and neck cancer, which I'm slightly different from the other panelists. I'm mainly solely a head and neck oncologist, and my practice has changed. My practice is the chap on the right hand side is younger generation. I'm seeing all HPV related cancers and non-smokers. Yes, we in Birmingham, which is the second biggest city in the country, we still get inner city individuals who smoke and drink. So that's something you need to be aware of, and all of you know that. So this is from one of my chapters from UK consensus document, which we use as a Bible for us in UK. And this is the number of laryngeal cancer cases in UK. And one thing you need to remember that, the mortality, it's not has improved significantly, but for early cancers, guys, the survival is very good, and whatever you offer. So something you need to bear in mind. So again, this is from our UK consensus document, and you can see that if it's an early T1 tumor, you offer them radiotherapy, the TLM, the TORS, this open supraglottic laryngectomy, which is more common in other parts of the world, and you get similar sort of survival rate, and you're getting near quite good survival rate. But as you get slightly bigger, like T2 tumors, the survival dips a bit. And again, there is, the studies are there, showing 2-year and 5-year survival, and ranges between 80-90%. So that's something you have to bear in mind. So you are now starting to talk about how you're going to give this individual good quality of life at the end of their treatment, because you don't want to leave these people with baggages, and you want to, especially the baggages of radiotherapy or a chemoradiotherapy, etc. Something I can't go away. I know I'm talking about supraglottic cancers, but T3, and that's from our American colleagues, this is something has changed the organ preservation for T3 tumors, at least in my practice. T4 tumors, we still offer them laryngectomy. So endolaryngeal surgery, something I can't go away. One thing is important. You need to do a relook procedure, as our colleagues were talking about, but the cost effectiveness, because we in National Health Service, we have to be very careful about health economics. It goes away from health cost effectiveness. The other important thing, which you have to remember, guys, this is a paper from Glasgow in JLO 2005, and it's very important. Smaller cancers, the biopsies removes the cancers. So what's the point of offering these people radiotherapy? And CO2 laser, we've spoken about it at length, and they've gone too far in, so I'm not going to dwell on it. But you also need to think about margins. For supraglottic tumors, you're talking about 5 mm or more margins you're talking about, whereas glottic is slightly smaller. So it is important. This slide is from Toronto, everybody knows. And what I just want to show that how things evolve. They evolved from the days when I was a baby doctor, where we used to talk about commando operations, etc., to transoral surgery, first as a laser surgeon, then as a TORS surgeon, and how things have evolved. And also in radiotherapy world also, they have evolved significantly, and you can't discount that. And also, don't forget HPV and its implications. So with regards to robotic history, 1985 it started, and then 2003 when we started talking about the intuitive robotic system, which is still is the main and sole resource for robotic platforms. We have got Medtronic's experiments, have got some stuff coming along. There are other robotic platforms available, but still gets dominated by intuitive robotic system. You've got X-Eyes, and now also you have got a single port robot. I believe single port robot will be probably a bit of a game changer. So this is something you have to remember, how we have progressed with the robotic work. And starting from 2003, 4, 5, and now what we are. we are doing quite a lot of stuff. And what I have not included here, I've been in a conference recently where people are doing retroauricular approaches and doing a lot of stuff. And I am absolutely certain things will be different when we do organ preservation surgery. And I know Sachin will show you how he's used some laser for glottic cancers with a robotic system. So it is important, those of you who are in the forum who are in the starting blocks, the robotic program, they are very stringent. It is driven by the governance. You have to have this, what I'm showing in my slides, and that's very important. And in UK, we are talking about 20 cases per annum somebody should do, and that's when you should be, carrying out that practice. So it's important. Again, going back to my colleagues, it is patient factor, what the patient wants, the tumor factor, which is very important, exposure, access, and where it is. And therefore, you must do what I call it EUA, which is endoscopic examination, so that you know the access is correct, and the healthcare factors. Why is it healthcare factors important? So I'll give you my example. I have got access to the robotic system twice a month, which means I haven't got it access every time. And you'll see in my presentation, I've used some laser videos because I still have to provide that patient care in a timely basis. So sometimes I end up using laser, and I still believe my laser skills slightly better. So this is, I always throw it in every single presentation. I don't believe you can do a proper supraglottic laryngectomy without this instrument. It's called FK retractor, and some of my colleagues in the forum might use something else, but that's what I use. So this is it's a Google picture. So this is how robotic makeup is. And you need a dual console ideally. That's the picture probably from 12 years back when I started the program in Derby. And if you have a dual console, you can teach each other what you're doing. So you should start with the most simple stuff. Those of you who are very junior in the forum, this is a pleomorphic adenoma of a soft palate. You want to do this. Why? Because robotic programs, very high profile, unlike your laser programs. You want to get the tick box from your medical director or chief executive or whatever it is, so that you do a mundane, boring stuff. And then you start doing this sort of stuff. So this is why the robot is important. And this is where the robot comes on its own. And you can see, it's a 3D endoscope, as the panelists showed other stuff as well with the robot applications. And it's the movement and etc. is so unique and so much better if you have the access, that it trounces any other technique. And again, this is one of my first kind of tongue-based mucosectomy cases. And you can see how your robotic technique allows you to get that access to the base of tongue. So again, once again, the access is paramount, as the colleagues were showing you in the previous presentations. So it is also important to understand surgical margins. And I will give you one little mantra for all of you guys. Please be friendly with your MDT, and you should also align yourself with your MDT, because if your MDT is more inclined towards radiotherapy arm, just be careful how you go, because it's important. We're still not the norm especially for supraglottic cancers. And the frozen sections, unfortunately, I don't have that facility, but that's what it is. And also remember, when you're doing bigger resections, deep versus mucosal margin, which is very important. So this paper I always quote, because this is what I try to fend myself as a transoral or oncology surgeon. This is a paper by Professor Pelleri, and you can see he has liaised with everybody around the world, and he basically showed in the RECLUT trial, which is interesting, 1 millimeter is good enough for those patients. Remember, this group of people are getting immunotherapy as well. So the patient selection is key here. So complications, I think what I'm going to touch base about the complication is you look at any transoral robotic paper, there is a 1% death rate, mortality is there. And also you have to remember there's a gastroscopy rate associated, especially with the supraglottic resections. So this is a quick overview of what do I do, and you can get it from the recording, and I won't dwell too much because time is of essence for me as well. So narrowband image, the colleagues have spoken about quite a lot. Now, it is important for early tumors. I believe you do get comparable oncological and survival benefits to radiotherapy with whether you use TLM or TORS. And, it has got multiple advantages. And however, there's a wide variation in this. I've used for late diseases in the past, not anymore, as I've become a bit more senior and I've looked at my results. So this has been shared by a previous speaker, and it's very important to understand Steiner techniques, which is sometimes can be alien to some of us, but it's very important. Again, similarly, I'll just say one important thing. Try to think about where the arytenoids are, how much you remove. And even in some of the papers, it's very important. There is an ELS, or European Laryngology Society classification for supraglottic laryngectomies, but sometimes you don't adhere to that. You go into a case and you find what is best for the patient. So it is not easy to define an operation into a kind of whatever the type is. So this is important. So if you look at this paper, and this paper is from 2014, and which basically says what most of us know. TORS is very comfortable. You're sitting down and doing it in a comfortable comfort of a chair, and you can rest your head on the console and do the job. Whereas with a laser, you're basically sitting, no head support, etc., and you're doing it for a length of time. However, when you're looking at the exposure, and I still believe I feel more comfortable with the TLM than with the TORS, because with the robot, you have to put the arms inside. And I also would suggest don't try forming a supraglottic laryngectomy, the robot, or even the laser, until you have done 40, 50 of standard oropharyngeal cases or a glottic cases with the lasers on the lines. So it's important that it's a higher level skill. So something to bear in mind. This is, again, it's a paper which basically been published in 23, and it what is counterintuitive, you can see that with a robot you can get an on-block resections with a 5mm margin, and which I can assure you that is possible. So you need to look at what we are looking at, whether do we get oncologic and functional outcome. And this is a paper which basically shows that you do. So this is a very important thing which I wanted to share, the functional outcome of your T1, T2 supraglottic laryngectomy. This is a paper, again, 2018, and they have done some comparisons. So it's a systematic review, and 10 articles they chose. There are 640 patients. So, but one thing you can, when you read between the lines, they couldn't compare, but that there are some take-home messages from it, for supraglottic laryngectomy. When you're counseling a patient, there is a group of individuals who will have some aspiration. And do radiotherapy patients get respiration? Absolutely they do. So you can counteract that argument in an MDT. And the last but not the least, which I would like to emphasize, is that gastrostomy is there. And you can have patients who needs a G-tube or a PEG or a rig, whatever you want to call it, for patients who are undergoing supraglottic cancer treatment via whether it's organ preservation surgery or with a radiotherapy stuff. So it is important also need to remember that the tracheostomy needs for supraglottic laryngectomy patients. You have to understand which group of patients will need tracheostomy. In my opinion, and if you look at this paper, older patients need tracheostomy. It's a short-term temporary measure because remember, patient can die from this operation. So you want to prevent how you're going to stop that, right from asphyxiation, from the bleeding or swelling, or from, you just want to make sure that you want to allow that area to settle down. So this is something important. This is a picture of one of mine from supraglottic laryngectomy, the laser, as I said. And this is one from supraglottic laryngectomy with a robot. The other thing I was going to stress on, how you're going to send the specimen to your pathologist. I'm using a potato biomount. You can use a breastboard. You can use a cucumber biomount, whatever you are. But orientation and pictorial orientation is very important. You need to take some pictures, and those photographs needs to be sent to your histopathologist. It is also important to understand when you're doing a supraglottic laryngectomy, you can encounter the blood vessel and you need to use Liger clips or what you think is the most preferable option. So this is from 2 weeks back. I had a 45-year-old lecturer who came to me because we are the main sarcoma center for whole of south of England, and it's a solitary fibrous tumor of area epiglottic fold. So I ended up using I used laser. That's the ultimate result. And as I was saying, you need to spare the arytenoid area. So this is a short video, and it's basically so you can, you just go and you are excising the tumor. And what you need to understand with the supraglottic solitary tumor is that you need to have a proper look at it with the histologically to find out what grade it is. Because if it's a low grade tumor, what I would end up doing, you'll see that that'll be more than good enough. And you might need a bit of radiotherapy if necessary to basically stopping this patient having more aggressive surgery. And remember, I just want to, one of the important factor here is the patient factor. He's a lecturer. He wants to function normally. And now you'll see when I'm taking the margins, I will encounter bleeding. And what you need to be that, you need to be comfortable stopping the bleeding. And that is very important. And you need to take the margins, and you need to, again, engage with your multidisciplinary team to basically discuss and go forward with your treatment. So this is, again, this is a published literature. This is one of my first few cases. It's published in Clinical Otolaryngology 2014, and it's looking at survival rates. And then as I said, I used to practice for some of the T3 and T4 tumors, which I've gone away slightly because I've realized that the outcomes aren't as good as for T1 and T2 tumors. Again, this is published literature, is there. And going further forward, I'm just going to show you a couple of videos before I end my talk. So this is a patient with quite a lot of us have done probably, supraglottic laryngectomy. And the guy, 4 or 5 years down the line, he continues to smoke. You can see some effects there, but it's a good result. He's happy and he's continued to live without any problem. Now, this is what you don't want. So you can see this is a guy with a T3N1 M0 hypopharyngeal tumor with some supraglottic involvement, and I've removed that followed by post-op radiotherapy. So gentleman has a tracheostomy in place, and gentleman is dependent on his gastrostomy tube. I don't want that to happen if I can, and that is the important facet. However, one last thing I will say about this gentleman, I remember him very clearly. He's now, I think, he's in mid to late 70s. He is happy because he's disease-free. Because I'll share one last thing is that while he was undergoing this treatment, he used to be coming with his wife, who unfortunately developed esophageal cancer and died from esophageal cancer. So what his reflection was 5, 6 years down the line, he said, Mr. Day, you've saved my life and I'm happy with what I am. So again, it's patient specific. You can't just say, oh, you've done a disaster. You've given a guy a tracheostomy and a rig. To be honest, he had this operation. He lived in Midlands and now he's gone to Norwich. Those of you know in England, it's a beautiful part of the world where Mr. Oswald lives, seaside resort. So he's happy that he's alive, he's functioning, but his wife who had esophageal cancer is no more. Now, two last slides. So this is there in our UK consensus document. You get a T1, T2 cancer. Going back to our colleagues, you have a good access, you have a good pulmonary function, is very, very important, that is, then you go for your TLM or TORS. And you got a good clear margin, no radiotherapy. If you have a positive margin, we now know from the literature that you do a repeat surgery, second look surgery, and if you are clear, then and the MDT, which is multidisciplinary team or tumor board, whatever you want to call it, then you don't give anything. However, if the second look, if it's positive, the recommendation would be radiotherapy or even some of the places where you're going to go for chemoradiotherapy. Whereas where there's poor endoscopic access, then you go for non-surgical mode. So that's my last slide. And the conclusion is, as I said in my little spiel in my website, you have to have a personalized evidence-based approach. You need to know what the evidence is there. And it's very important. It's MDT driven. You don't decide for yourself what you want to do. And that is one of the probably the best things that happen in UK, especially. We have tumor boards. We discuss it on a regular basis, and it's led by an MDT chair. And you also have to compare what the oncological and functional benefits are. And If you can, please be part of a randomized controlled trial.
Thank you
Thank you
very
very
much,
much. I
Muganka.
think
Thank you. Fascinating, practical points as well. I think we're really running out of time. So, Sachin,
Yeah.
are
I'm
you
going
able
to
to
share.
show?
Yeah.
And then we'll cut short on discussion. I think Paul Bryson might have a couple of things to say, and then we'll conclude the session after that.
I'm not going to go really in the theories. Just show the clips and okay. So basically it started with punch forceps and now we all know CO2 KTP and it's a low cost one stage therapy, patient admitted in the morning and discharged in the evening or maybe next day morning and then he's back to work. So it's a one session management plan as we compare with radiation. So the best possible for CO2 laser or for endoscopic laser excision is the lesion should be mid-chord and again a good exposure, easily exposed larynx, anesthetic considerations. Of course, when it is a mid-chord lesion, the results because of good excision and adequate margins, the oncological results are going to be superior than the radiation. Now, as we see the functional results, so basically what functional results the patient is going to ask is voice preservation. So you have to preserve the mucosal wave, minimizing the thermal damage because you're using laser. There is always going to be a neocord formation, like a fibrosis there, and it's going to get rid of the defect which you have created with your laser. Compensatory is again ventricular phonation. So around 15 to 20% of the patients are going to have good voice for their day-to-day activities because of compensatory ventricular phonation. We have already seen this with the help of eye scan or NBI. Preoperatively, you can have a good interface between a normal mucosa and the pathological tissue. What the principle, which I'm going to stress again and again, is optimizing the preservation of the normal mucosa. So you are going to limit your surgery to the lesion and preserve the normal mucosa on the same vocal cord and of course not injuring the upper vocal cord. And that's going to give you the best possible functional outcome. Now we have heard about the margins. So what's the margin? Because the papers have come which say you can have ultra thin margins. So this is just a clip which would show you what the margins. I mean, we say 0.51 millimeter, 2 millimeters margin. So how really is it? So this is a 0.5 millimeters distance from the tumor edge, and this is a 1 millimeter margin. So 1 millimeter margin is adequate to resect the tumor with a good oncological result. So this is 0.5, which we may consider as ultra narrow margin. But I think to start with, you can have a good adequate margin, and that is 1 millimeters. And 1 millimeter, 2 millimeters would be double than this. So it will end up here. So you will lose maybe a normal mucosa quite a bit along with the tumor, and that can have maybe a compromised functional results. So oncologically and clinically, 1 millimeter margin should be adequate as you resect your tumor. We have already seen this hydrodissection would again limit the thermal damage and give good possible results. So this clip actually shows the ventricular phonation. Sorry. Really done on a high-speed camera, you will see how the compensatory mechanism works. So these are the ventricular bands which are approximating and giving good adequate voice for his day-to-day communication. The same principle, preserve the mucosa surrounding the tumor. So this was a type 5A chordectomy. Tumor was in the anterior commissure. I have resected it. It resulted into formation of the anterior web because of the raw area on both the cords. But patient has a good phonatory outcome. And you see this on a high-speed camera. The mucosal waves on the normal vocal cord are quite good, and that gives good phonosurgical outcome. So again, principle of phonosurgery is preserve the mucosa surrounding your excision. So this NBI and all these things preoperatively are going to allow you to do this. Again, going to the European Laryngology Society's classification to understand how deep we go and resect our tumors to have good oncological results. And as deep you go into the vocal cord, we classify them as type 1, type 2, type 3, type 4, type 5, and type 5, 6. So only to the now I'm going to explain you on the slides, clinical sites. So only the superficial epithelium would be type 1. So you resect only the epithelium. So leukoplakia, CNC2. As you go deep and include the ligament also, it becomes type 2. So epithelium and ligament resected, that becomes type 2 chordectomy. You go deep and have 2/3 of the vocalis muscle resected, that becomes type 3 chordectomy or transmuscular chordectomy. And when you reach the thyroid perichondrium, it would become type 4 or complete chordectomy. Extended chordectomies, when tumor goes onto the cartilages or above and below the cord, or go on the opposite vocal cord, then if the cords are mobile, then maybe transfemoral laser surgery would suffice. So accordingly, we have divided the chordectomies. The type 5 chordectomy, if you resect the anterior commissure and part of the opposite cord, that becomes type 5A. Going into the arytenoid cartilage, type 5B. Going to the ventricular fold, type 5C. And 1 centimeter, up to 1 centimeter into the subglottics, then type 5D. We have already seen this. For the good exposure, only I would like to suggest, while putting in the laryngoscope, you should remember the distal end of the laryngoscope should be directed laterally to the deceased side. That means if the lesion is on the left vocal cord, then the tip of the laryngoscope should be directed towards left side. So that is why you are putting in the laryngoscope. We are going to just see whatever already have been described in the previous presentations with the short clips. So first is examination. So this is a 0 degrees laryngoscope, and you see the margin of the tumor. Just to know about how this examination with 70 degrees is going to help. So anterior commissure, ventricle, and under surface of the vocal cord. So this is the anterior commissure. So it is free of tumor. The under surface and laterally the ventricle. So these sinus endoscopes are available in everybody clinics and OTs. So you can just use them and do the scopy and go ahead with the resection. Now you can use the ventricular retractors or false cord retractors and have a good exposure of the lesion. Again, hydrodissection to know the margins, adequate resection, and to reduce the thermal damage of the laser. Intraoperative NBI, false chord excision we have already seen with the clip. This is with the CO2 laser. You just resect the false chord. And the region is well exposed for resection. First, you mark the incision. So adequate exposure, then mark the incision from anterior to posterior end and the undersurface also. Then start the excision. The excision also always has to be go from below upwards or posterior to anterior, because if there is a bleeding from some small blood vessels, then it's going to trickle down and not obscure your operating field. So this principle has to be, so never resect from anterior to posterior, always go from posterior to anterior end. Clean the charred tissue to have a good healing, and then you complete the excision with the CO2 laser. Now again, how you differentiate the surgery with KTP and CO2? With KTP, you are vaporizing or ablating the tissue. The margins would not be there for examination. And with CO2 laser, you have got anterior, posterior, lateral, and of course, the base of the tumor available for examination and to give a certificate of oncological clearance. So this is the post-excision, again examined with 0 degrees and 70 degrees, the anterior commissure, the undersurface, and the ventricular band. We already seen, but just know your pathologist. The thermal energy is going to shrivel the tissue. So they should discard the first millimeter of the specimen and then start examining the deeper to 1 millimeter. Because if they examine the margin you have sent, that's going to come as negative margin because it has got damaged with the laser's thermal damage. Okay, so always have a discussion with the pathologist and how to examine the histopathological specimen we have sent. Again, the vocal cords are not like a paper. They are three-dimensional structures. So it always has a base. So you have to see how deep you are going in excising the tumor. Okay, like varicose CA, which are quite superficial. So you can do superficial dissection with hydroresection, and the vocalis muscle and the deeper tissues are there for functional outcome. And the incision always has to be linear. That is the principle you have to follow for good approximation post-operatively and functional outcome. Not like a circular incision. It always has to be a linear incision. Go fast on the classification of the chordectomies as we see or we do. So these are leukoplakic patches. This is pre-operatively. This is post-operative. So only the epithelium has been resected. This is carcinoma in situ. This is post-operatively. So only epithelium has been removed. This is actually a tumor. I have excised the epithelium and the ligament, and this you can see the bulk of the vocalis muscle intact. So this becomes type 2 chordectomy, including the epithelium and the ligament. Type 1 and type 2 chordectomies leave behind the muscle mass, and which gives good functional outcome. Okay, so just see. Now, I have resected this, done type 2 chordectomy. This is post-surgical stroboscopy, and you can see good vibrations on the operated cord also with good approximation. So you have to reduce the thermal damage with localized blocks, local cryoprobes, and all the methods which we learn like hydrodissection, and the vocal outcomes are quite good. As we go deeper, then you lose the muscle mass, and then there is a phonatory gap which is there, which gives hoarseness to the voice, and then what we call as unsatisfactory vocal outcome. So it becomes wide glottis, stiff scar tissue, hoarseness. So Mark Remakel has a presentation, and it says around 7% of all corticectomy patients and around 17% of total and extended corticectomy patients consider their voice to be insufficient due to significant glottic gap or anterior synecdoche, and they are going to come back to you for the remedy, and you have to think of some reconstruction of these patients. Okay. So we have already seen type 1 and type 2 corticectomies are voice preservation surgeries. Type 3 is you lose bulk of the muscle mass, and which results into the phonatory gap. So this is a lesion has undergone type 3 corticectomy. 2/3 of the vocalis muscle has been removed, resulted into the glottic chink and hoarseness of the voice. This is a lesion going up to the thyroid cartilage, and this is what results. He has lost all of his vocalis muscle, and the incision is going up to the thyroid perichondrium. So there is no muscle mass here also. So he is going to require phonosurgical correction for his glottic gap. This patient, because he has type 3 corticectomy, okay, this is extend. Okay, we'll just go fast, and then I will show you some clips of voice construction. Type 5A corticectomy, so going into the anterior commissure and opposite vocal cord. This is 5A. This is a clip, but this is what it looks after the surgery. Now, this is a lesion in the right vocal cord, underwent type 3 corticectomy and lost muscle mass. And because there was some muscle present there, 1/3 of the vocalis muscle, its place for our augmentation, that is with fat, available. So in that muscle mass, we injected the fat and we augmented the vocal cord and got rid of his phonatory gap and the hoarseness. So this is pre-surgery. This is after resection and primary fat augmentation. Now, when you inject fat, let's say a patient of unilateral vocal cord palsy, then you inject around 1.5 to 2 milliliters or 1.2, 1 to 2 cc's. But here only 1/3 of the vocalis muscle is available. So you inject only 0.3 to 0.5 ml. If you try to inject more, then it's going to come out of the resected fat. So remember this. I'm not going to show you the surgical clip. This is after 12 weeks. Good vocal outcome. For anterior webs after type 5A corticectomy, you can remove the synecdoche, put in a the silastic sheet or this one, and then resect, and you can have the good approximation and vocal outcome. For type 4 corticectomies, when there is no muscle mass for our augmentation, you can't inject anything because there is no muscle available. So type 4 corticectomies, extended corticectomies, you have to do thyroplasty, medialization thyroplasties for this patient. There is another thyroplasty, which is anterior laryngofissure and putting in the thyroid ala to take care of the anterior commissure gap, like type, suppose the growth is in the anterior commissure and you have resected the thyroid cartilage also, then the gap is going to be there in the anterior commissure, and then you can do the thyroplasty, which has been described by Zettel et al. To push in the thyroid cartilage and get rid of the clotting ching. 5-year survival rates are around 93.5%. Laryngeal preservation is around 99% in the article which I have published. This was in 2015. Again, I have published in 2018. I also published the article for autologous fat augmentation in type post type 3 chordectomies. We have compared phonatory outcomes between laser chordectomy and radiotherapy. The results are phonological results are quite equal in both of these methods. Again, high-speed video laryngoscopy in all these patients to check the preservation of the mucosa and the mucosal wave. Just to end, this is application of robotic chordectomies or robotic resection of the tumors in the difficult areas. So this was in the anterior commissure, a big mass. And with the CO2 laser fiber. I have resected the mass and sent the tissue for margin. I mean, a lot of newer things coming up, and we should learn from more and more technological advantages or advances which are available now. Just to end and some comment on Dr. Bharat's margin determination and newer methods to check margin. We had a lecture in our last conference on artificial intelligence in laryngology. And that brigadier, one of my good friend, Dr. Datta, he said, now the artificial intelligence or the computer is going to tell you, surgeon, please have more margin. Because now the computer is going to decide whether you have resected adequately or not. So now we are heading towards most advanced and maybe independent things, independent decisions. Thank you for your hearing, and I will request Mr. Oswal to take over.
Thank you.
And his comments.
Thank you very much. Thank you, Sachin. It's been fascinating journey, really. It's wonderful. I just want to show you the book, Lasers. Those who want to know about the lasers, I recommend. I published that book with Mark Ramakkal in 2014. That's 10 years ago. And Steve Zeitel is co-editor, and Bob Satloff and all my co-professionals in that era contributed to this book. It's 914 pages, published in 2 volumes. Okay, it's a first edition. No, it's a second edition, but in volume 1 and volume 2. So I think it's been a good topic, good presentations. I would like Paul Bryson, if he's still there. Are you there, Paul?
I'm here.
Paul, would you like to conclude the session?
Oh yeah, I thank you for that. And also I wanted to thank everyone for the for the opportunity to participate and join. And I really enjoyed the presentations. I want to congratulate everybody on their innovation and their outcomes. It's really I'm always sort of inspired and motivated when I see people, trying new technology or showing their results for this sort of work. So thanks. And I look forward to being a part of the panel and hopefully joining everybody for additional grand rounds.
Yeah, thank you very much. Again, as usual, we've gone over the time, but can't help it really. Maybe next time you want 2 hours of session, Sachin. You pay for it yourself.
But
So
as I see, I would like to thank all the participants. I mean, the number is increasing as we are going past our time. So I think that's good.
I think the important point again for those who are new, like Bharat and Paul, we have the global audience. Global audience means Asia Pacific and this, not the other. And let alone 2 lasers, but people don't have even 1 laser. And it is aimed at those people. They still have the patients. They still go to radiotherapy. It produces them the results. There's a loss of income for a surgeon as well when the patient goes to radiotherapy. In one of the mock conferences in Delhi, Sachin Gandhi was put on the spot by a prosecutor asking him, how much money do you make per year on laser surgery? He was pummeled. Do you remember that, Sachin?
Yeah, absolutely. Yes. It's
So
fun.
this is the
Yeah.
kind of thing our surgeons have to decide as well. When they actually send the patient onward for radiotherapy, they're losing the income. This is something that doesn't happen in the UK because we're NHS, but in a lot of private practices, I think there is some consideration that is given to surgery more on that basis. So there's a
Yeah.
lot of
There are
variation.
there
And
are two questions
again,
actually, sir.
a
Uh,
question
what is
from audience? Yeah.
Best contraindication for office based KTP photoablation.
Oh, so I can take that, and feel free, Paul and Bharat. I know that we're running over time, so if either you have to jump off or join via cell phone, feel free to do that. But initially, you want to find a patient that's an adequate patient, a patient with a significant gag reflex, or one that doesn't like procedures or has trouble with procedures. That can be a tough patient to treat in the office. You want to make sure that they're appropriately topicalized. So that includes not only aerosolizing lidocaine, but also, like you saw, dripping lidocaine onto the larynx as the patients are phonating on knee. You want to make sure that you have a very good working channel scope with sort of ideal optics. You want to make sure that you are in a place where you can sort of deal with any potential complications, including vasovagal, lidocaine toxicity. Ideally not, you're not going to run into an airway obstruction issue, but, you really want to make sure you're finding the right patients here. And again, you want to look for patients that have disease that's limited. You don't want a patient that has a significant footprint of disease because it's better just to take them back to the OR.
Yeah. And
Okay.
thank you,
Any
Brandon.
more?
Yeah,
Any more?
and this is for Paul actually.
Mhm.
Any specific instrumentations in making for lasers in robotic surgery for glottic CA? Because whatever available as of now with the company, they are actually
Oh, yeah, yeah. So from any specific instrumentation, yeah. I mean, I will tell you, I don't do a whole lot of robotic surgery, so I hope that Bharat would chime in too. But my understanding is that it remains an access problem, even with the single arm and the smaller instrumentation. So I think that size probably matters right now. I think there is a number of things that would lend itself. I think just the fiber delivery system on the right instrument would work great for robotic surgery. And I think we may even see some innovations for other types of devices that can go through channels and whatnot that can help you work, perhaps perpendicularly or in a side firing way. I think those of us that were up with Dr. Zeitel's, there's some instrumentation in our sort of, sister and brother subspecialties, urology. If we look in the space for submucosal surgery with GI, we may find instrumentation that can apply to the larynx. I'm thinking specifically of side firing lasers that they use probably in urology for the bladder and things like that. Sometimes it's a little bit of going maybe down the hall or looking at the your neighbor operative theaters and see what they're using.
Yeah. There is only
Any more?
question,
Any more?
opinion actually, opinion
Yeah.
from the senior surgeons, and a localized sarcomatoid tumor, bilateral vocal cords mobile. Still, you have to go in for a radical surgery or Orodectomy, I don't know. Yeah.
My take on if it's the sarcoma
Yeah.
discussion, because I've had, I think, a run of them. So best example is the case I have. If you go to a sarcoma MDT, it's usually led by a general surgeon wherever you are, and they talk about margins. And when you talk to a pragmatic sarcoma surgeon, they will say the margins are really not defined. It's similar to us guys. So, when head and neck sarcoma surgery is different from abdominal sarcoma surgery, that's the first thing to take. Second thing, you need to do what's best for the patient. So for my patient, what's the best thing? If it's a high-grade solitary fibrous tumor, you're going to do a laryngectomy or at least a partial laryngectomy. This guy is a 45-year-old, highly educated lecturer of economics of University of Birmingham. You're going to change his life for good. So that's why the discussion, when you look at my letter, was very clear. I'm going to do an endoscopic resection, either with a robot or a laser. I'm not going to address your neck. We'll find out what grade of tumor you have, and then we'll give you radiotherapy. With the caveat that if your cancer going to come back, I'm going to do an open resection, be it an open partial supraglottic laryngectomy or a total laryngectomy, and then you'll get the correct margin. I hope that clarifies what they were looking for.
Okay.
Okay, thank you. Any more?
Yeah.
I can't start my
They have been
video,
covered. Yeah.
but I'm still here.
Yeah.
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 Any more?
No,
No?
they have been
No.
covered. Yeah.
Well, all I got to say is I'm very lucky to be still here. I'll be 90 next few days. And to interact with the young people, I just have to thank somebody, and I don't know whom. So thank you again and again and again, and we'll see you next time. Okay? Thank you. Bye.
Thank you so
Thank
much.
you, Bharat.
Bye.
Thank you, Paul.
Thank you.
Brandon
Thank you,
again.
Bharat.
Mruganka. Welcome. Thank you.
Thanks for having me.
Have a good day.
Appreciate it.
Thank you.
Thank you. Thank you.
Thank you very much.
Thank you.